Thank you very much for being here at the Rural Health Transformation Program Grant Application Working Group Session number 4. And those of you who thought I couldn't read, I've disabused you of that notion. For those of you who don't know, my name is Mitch Rowe. I serve as the Secretary of the Family and Socialist Service Administration. And we'll be walking through today a series of slides and updating you in terms. If you're just a minute, we're dealing with auditory issues. And we'll be walking through a series of slides, kind of updating you on kind of where we are. We're hoping to put this to bed. Tara and et al. Are hoping to put it to bed yesterday, but we still have some more refining to do. We are planning on submitting it on the 3rd of November. I'm going to talk about something else for a minute other than, well,
hello.
Other than the Rural Health Transformation Act. Many people on the phone are engaged in a variety of human service activities. And we thank you for that. Unless the federal government reopens its doors by sometime at the latest early next week, the federal government will be unable to load food stamps or SNAP benefits onto the cards. And on November 3rd, food stamps or SNAP benefits will not be available to recipients. There's nothing I can do about that. There's nothing the governor can do about that. That's a federal issue. So if you didn't know that, I wanted you to. Okay. On that happy note, Tara, can you walk us through the slides, please?
Yeah. Just make sure everybody's been admitted. Okay.
So I'm sorry, my partner in crime here is in Washington, D.C., so she's unable to be in person. I don't know if she's able to join by phone or not. Yeah, okay,
I'm
so
here.
she's in D.C. Oh, you are? She has an excused absence. Physical absence. Okay, so let's go through timeline review. Go ahead.
Okay, so we're going to run through the timeline review, preview the ongoing stakeholder engagement model, and then discuss initiatives and provide feedback. Note that the initiatives being shared in the working group are not final and are still being contemplated, so we appreciate your thoughts and feedback. So I know we're presenting a lot, but we have to have content to present, so there might still be some really great ideas that haven't been included. So moving on to the next slide. So again, our timeline, we're moving right along. Today is the 21st. We have a really good draft going, but as I said, we still have some ideas that we're contemplating. So after this working group meeting in the next 2 days, we should have a really good draft, more finalized. There's a 20-page budget narrative, and so all of that is dependent on what initiatives are being complete. So that's why we don't have a complete draft, but we are confident we will hit our deadline of submitting it on November 3rd. It's due on November 5th. So we have remained on time as expected. The next slide is our ongoing governance structure and stakeholder engagement. It looks similar to what we have currently presented for the working group. I think that, as we look at this, there are going to be engagement opportunities for working group members who have been identified to continue on the steering committee or the advisory committee, both as we go forward in making decisions. So we'll have a Rural Health Transformation Program Grant Director, and then we'll have the Chief of Staffs from FSSA and IDOH really helping direct that steering committee, and then some additional working group members on that. And then there are also other opportunities if we look at the advisory committee, especially when we look at the regional health grants. That's going to be really important to have engagement across the state within the regions so that we can ensure that people or groups are engaged the ones that, are expected, who this is supposed to help in the rural health communities. And then the initiatives, again, don't be alarmed. We're listing what we have today. This is
income limits
not
and that
this-
kind of stuff when you.
If you're online, if you could go on mute, that would be great. Thank you.
Hey,
Stay on mute.
I'm not sure you're sharing your screen. I just got a text from Dr. Smith.
Oh, I apologize. So you can't see it? I can,
Maybe confirm with people online, see if
I
they
can
can.
see it.
Or
on
maybe
the
it's
other
just a-
computer.
I can see it.
If
I
the
can see it.
users
Okay.
online can click the PowerPoint icon that was in Teams, it pulls it up and then follows along.
Gotcha.
Thank you.
If you can't see it, you might want to call back in again. Sometimes that helps.
Okay. And then, so again, the initiatives, this is what we've listed. So, we need to have something on paper that's written. There's a lot underneath each of these words. So as we move forward.
So
as-
Tara, just to
Yes,
clarify,
Yes,
these work groups have not been created yet? Okay.
we have to present our structure in the application. And so it'll be further vetted in the next 2 weeks. But this is what it's looking like right now. And then next slide is this was presented last time, so I think we just wanted to remind kind of the structure. So we have state level initiatives. And again, I think people have concerns that means we're addressing large hospital organizations. Statewide initiatives really are more about technology, improving access that need to happen at the statewide level. But there's also a component perhaps in some of them at the regional grant level, but we need to address it at the statewide level. So I hope that that's clear, but the focus here, 100%, CMS is very clear. The focus here is on Indiana's needs and our rural health communities. So I wanted to level set that. I won't spend too much time on this slide because it was in the packet and it was presented last time. So we'll kind of hold for questions till we go through kind of how this is structured, if that's okay. Because it might have been confusing as you were going through the slide deck. On the next slide, we have, remember there were 5 CMS goals. And so what we've done here is map the initiatives to the CMS goals. So it's just a different way of looking at what was on the previous slide, but mapped to the CMS goals. Because again, that's going to be really important. We have to continually do that as we're speaking to this in the application this is a great initiative, but how does it align with the 5 goals? And some of them cross different goals, but we selected like a primary goal that's addressed under the CMS umbrella. So any questions on this? This is really just mapping what was on the previous slide to this. Feel free to admit anybody who joins the meeting if I miss it. I think anybody who's in the meeting can admit somebody, so feel free to go ahead and do that. So now we look at the Indiana goals. So we set some goals because again, that's something, so there's the CMS goals and then Indiana has to set some goals. And those are really underneath our goals is where our initiatives then map. And again, you can see that to the CMS strategic goals. So we wanted to really kind of go through this because it gets confusing when you're talking about goals. Whose goals are we talking about? And then Indiana sets goals, and then we have all these initiatives under our goals. So the first one is empower rural Indiana regions to drive community-specific solutions. So that really addresses our regional grants. And we'll talk a lot more on the next slides. We're going to dig into each one of these. But we, again, wanted to present it in a table so you could see it all at once. It's a lot of information. As we go through the next few slides. So this is really the overview of what Indiana is looking like right now from an application perspective. And then the next one is meet Indiana rural families where they are, connect disparate systems to centralized care coordination, and then grow Indiana rural workforce. So again, it's we really try to, they mentioned regional grants and the NOFO. Workforce is something that's mentioned over and over, meeting people where they are, meaning their health outcomes and, what's happening, why are they not accessing care? Why are they not taking their meds? Those types of issues. And so I think this is what we've tried to capture in those 4 Indiana goals.
I think the other thing, if I may, Tara, try
Sure,
to
please.
point out here too, is as we're thinking about these goals and we're thinking about the initiatives, aligning with what the NOFO asks us to think about sustainability, teaching people how to fish is something that they've said on a couple of different national calls. So ensuring that we're building and providing infrastructure building for local communities and statewide communities for longevity of this project. So that was kind of the frame of mind we took in when thinking about these goals and thinking about these initiatives. What's going to set us up for, working on this far into the future.
Tara, if I may.
Yes.
If we're in the room, will you announce who you are?
Sure.
Because they can't see you online.
Yeah, thank you. This is Eden Beasy. I'm with Health. Thank you very much.
Thank you. Okay, next slide. We will start digging into the individual areas. Back to Eden.
Can I ask a broad
Yes.
question, and if this is more appropriate for the end?
Who's speaking?
Oh, Ann Hazlett with Purdue. I'm a work group member. Is it expected that we have certain budget allocations for each of the goals, or is that a decision that would be made once the initiatives are fixed, how we're going to allocate the dollars?
I think that kind of plays out. So with the initiatives, people have, we've received initiative ideas. And along with those have come dollars attached to them. So as we're kind of vetting through those, there's a dollar figure attached to the middle column. And then that rolls up to what the goal would be. So we'll have to assess, does this feel right? I think that's where we'll probably be coming back and really looking at that to make sure that we're addressing the needs adequately from a funding perspective. Thank you for that question. And I will turn it over to Eden.
Thank you. Yeah, this is Eden again, and that is a really good question to kind of lead into this next piece. The first initiative that we'll be talking about is this Make Rural Indiana Healthy Again Regional Grants. And frankly, this is proportionally the biggest chunk of change that we'll be investing in Indiana. The idea here is that we will be, just like the feds are asking us to come up with our state plan, we'll be asking our regional teams to be coming up with their state plans on how they were going to improve rural health in their communities. Ideally, we'll be seeking approximately 8-ish applications from across the state, making up of hospitals, critical access hospitals, FQHCs, local health departments, EMS, community organizations to come together to develop these applications to be submitted to us to help make determination of how those dollars will be supported. There'll be requirements in those applications that meet and mirror the CMS NOFO that we've all been reviewing to make sure.
Tell me what NOFO means.
Yes, Notice of Funding Opportunity. Thank you. To match and mirror what CMS is asking us to do to make sure that translates down to our local communities. The idea being that, one, our communities know best what they need, and a single statewide solution across the entire state would not meet the unique needs of our rural constituents in their different locations. Frankly, different communities need different things, as mentioned, to meet kind of the broad health goals, although we do anticipate those goals being the same or similar across each of those regions. For example, what does improving access to early prenatal care look like in one area may look differently in a different area.
It will be up to the entities to coalesce together.
Correct.
Could there potentially be different factions in a given region?
Yep.
So like the hospitals could get together if they wanted, CBOs could get together. So this is a competitive process then.
There should be one grant application per region. And so our different entities will have to come together to submit one application per region. We want our hospitals to be working with our FQHCs, to be working with our local health departments, to really put that patient at the center of how they access healthcare, to reduce gaps in care, to reduce duplication in care, to improve communication between those entities within those regional organizations. And again, as I mentioned, setting up the infrastructure for longer term success.
So, if I may, in 2013, Governor Pence came up with this idea for what was then called regional cities. And I was the former Secretary of Commerce. He called me to his office. I told him that the communities never work together. They hate each other, and it can't possibly ever work. And then he said, well, could you help run it? So we did, and we managed to have enough money out there that it actually worked in 3 places. Now, I will tell you, down on the river in Jeffersonville, Indiana, it didn't work. They hated each other, and they refused to work together. And so how much money did they figure out?
Get your people in there.
They got no money.
None, right.
So they got no money. So, we lost something
I
here.
know. Go ahead.
So, there's a possibility that parts of the regions may create such dissonance within themselves that they get very little, if no money. We are hopeful that won't be the case, but we're putting a carrot out there, but the stick is,
They have to work together.
yeah,
This is Kara. I think I'll just piggyback off that, of what you both said. I don't know if I don't even know how you would logistically do it, but ensure some sort of feel-safe that that's not the rural region or the rural organizations and are not being penalized because others don't play nice. Like that's I think my fear
no,
is that
they
we
will
get
be.
into it.
No, I mean, they will be.
The rurals will be penalized if
If they can't play nice if they can't play nice regionally, right, they will probably receive less dollars.
How do you protect against the larger entities overrunning the smaller entities?
Because the state will, well, there's no perfect way, right? But that really has not happened in the READY, in what evolved into the READY program, right? So.
That's Pence's program.
And now it's,
2.0.
yeah.
Just a 2.0.
Yeah, so I understand it's scary for you guys. Okay, I don't mind you being a little scared because that will incentivize people working together. I know this sounds like a really tough love, but we've got to figure out a way. We can't have, in rural Indiana, we will not prospectively have the financial ability to have multiple LDRPs inside of 10 miles away from each other. We simply won't. We don't have the workforce. We don't have the money in Medicaid to fund it. We don't have that. So there's got to be some kind of regional planning in terms of how you want to deal with that. And, one of the reasons that FSSA is operating this is that we have a fair amount of dollars that we give to these facilities, right? Some of which is discretionary outside of this. We will use that to try to continue to incentivize appropriate collaborative behavior. It will not be perfect, but Dr. Weaver and I can't come up with another way to encourage regional cooperation. So this is where we landed. If you have other ideas, Okay.
I wish I did.
Right,
That's
right,
why I chuckle, because I'm like, I know I'm asking a lot of
Right,
questions,
right. No,
but.
I got it.
Yeah.
It's not perfect.
Yeah.
Right? And we've decided not to let the perfect, let the perfect be the enemy of the good, right? So that's,
In the way the READY model looks today, there's regional development authorities. Is that I mean, could that be viewed as the way you coalesce the regions to work together, as you identify
yeah, we haven't,
authorities?
we're kind of candidly not there yet. I think there's a debate, discussion about whether you simply just adopt the ready regions and go, that's what works there in economic development. Let's see if it works in health too, right? But rather than trying to completely reinvent that wheel.
When does that occur? Is that
It'll
prior
occur-
to funding or year one?
So the dollars for the rural health piece don't flow until the second year.
For the regional
Correct.
piece, yeah.
Right. So we have a little bit of time to get this squared away. And I anticipate that members of the General Assembly, some of whom are with us today on the phone, will be able to share their insights into how they feel about this as well.
Do you envision anything like on the match side, like you see in the READY program?
No. I mean, the READY program, I think, probably has a longer horizon than this does. Right? It's supposed to be a permanent operation. Hopefully, these groups cooperate and end up continuing to do so at the conclusion of the funding that's available. My guess is that some will. Hopefully, all will. I'm not Pollyannish.
Could you help me understand how we will align metrics? So in our application, we have to clearly say what outcomes we are expecting. So there's the CMS goals and there's the Indiana goals.
Correct.
I'm going to assume these regional grants will have to then roll up to the
That
Indiana
would be
goals
correct.
so that the metrics are aligned.
You are correct.
Okay.
So the initiatives will look different, but ultimately we're tracking the same outcomes
Yeah.
regardless of what the actual initiative is. Do we know what they are yet in the application? Have we defined the outcomes?
Getting there, haven't hammered those down specifically yet.
There's a question, have you considered incorporating strategic planning for each region? This approach would help identify the right parties, resources, and projects early on, ensuring that key relationships are established from the start.
It's a great question. My hope is that these conversations start immediately, and so regions have an opportunity to think about what their needs are, who their partners are. So when it's time to submit an application to the states, they have time to have a solid plan of how they're going to move forward, right? Because we need them to spend the money and demonstrate some success pretty early on in their projects. That's an interesting question about match. Thank you for asking that. I don't think so. I agree with Secretary Robe there. But I do think that there are things that we can build in an application that would kind of quote unquote strengthen an application. So who's at the table, how mature is their plan, what sort of ideas do they have that we could perhaps write to with this group's advisement of what would make a stronger application, what would we like to see there, which maybe would provide some opportunity for some out-of-the-box thinking across the region. I also think there's an opportunity for cross-regional learning.
Pardon, can I just,
Yes.
so I have a narrow version. When you say match, I think IGT for Medicaid, right? That's where my head went at. Her description here is a bit broader, I think, and maybe more
I've been
consistent with what you.
Thinking match, like READY match.
Okay, good.
Yeah.
I'll take back my no.
Thank you. Anyway, just to finish the thought there, I think there's an opportunity for some even cross-regional learning over the course of the 4.5 years that this would be in place. So again, what's working well in one region, we want to see replicated in another region, if that's the route that Erie wants to go.
Eden, we do have another question.
Sure.
Can you elaborate on what the 8 regions will be? How will those compare with emergency preparedness districts?
Yeah, that's a really good question. In my mind, they align closely with the emergency preparedness districts, maybe not perfectly. I'm really interested in understanding how patients flow and navigate within their kind of sphere. We chose 8 just kind of loosely based on those preparedness districts. Could land on 7, could land on 9. I think that's how we're loosely basing the application at this point now. And keep the questions coming because they're honestly very helpful as we think about building out the detail behind this, the application process behind this. So no question is like too basic, ask it, because we've all been staring at this for weeks now. So what seems obvious to us is helpful.
So what you
Who are
just
you?
said, sorry, Sarah with DMHA. I feel like you said one thing and then said another thing. You want the regions to start communicating and working and they have to be ready to go, but we haven't even told them what the regions are, right? Like, so, right, like, it may be 9, it may be 8, it may
Okay,
be 7.
so when we did regional cities, we allowed them to kind of form themselves,
Okay,
right? So, and we did that for the same reasons that when you build a new university, you don't build any sidewalks, right? You let people walk and then the sidewalk, you put the sidewalks in where the paths are. So we're gonna provide a degree of self-determination. If that self-determination doesn't happen, well, then people tell us that there we go.
And this is John. We actually met
John,
with,
where are you from?
I'm from Department of Health, thank you. We actually met with, in Sullivan County with a few like medical leadership in that area. And I will say, even from those conversations, we already started to see some of those partnerships or those ideas start to form. So I do think that there is that underlying ability. There were hospitals that were talking about like, actually, maybe we can share this. What would that look like if we actually had funding? Would this be something that we would be able to move between? So I think what, and Eden had said this before, this really replicates the way that Hoosiers are accessing their healthcare. So if you are a person in Park County and you are needing services, you're not necessarily seeing those those county dividers because you're having to go to Vermilion County. You're having to go to Vigo County. So what we really do is we need those areas working together for those entire areas that already have those significant needs. So I think that those will actually kind of, as we said, those elephant paths will naturally kind of create themselves as we start to see like how are people flowing into these systems.
I think Dr. Weaver wants to say something. Is it you, Dr. Weaver, that has your hand up?
It is, and I think actually John and Eden said what I said, but just to underscore, I know it sounds crazy, but these regions already do work together, these preparedness districts. And I think where there's the flexibility is a couple counties here or there where maybe there is an association based on patient flow that John just said. So our goal at the state is that we are going to review these applications. If we see anything that seems really off, like it is just, one hospital is clearly the only person benefiting from that, then we're not going to approve that. And also it's our job to make sure that every county is represented, but we're just saying we're not going to come out and say exactly how to do it.
So Cami again from CareSource, back again to the metrics. And you may not have thought this through yet, but what will be the reporting requirement for the regions? Because I know that, the grant has some pretty stringent expectations and even a clawback
Those will be the reporting requirements.
aligning with that. Okay.
This is Kara again. The outcomes that we talked about, which I know we don't have all the way yet, are they solely based on rural factors or is it statewide outcomes?
In my mind's eye, they are based on the rural factor. So they're the lives served in that area, which will then roll up into improving rural health across the state.
But the regions.
These are not
just-
going to be surprising, Kara and everybody. This is not going to be out of left field. It's going to be percentage of women who are getting, all prenatal care throughout their pregnancy. Number of women who are getting first trimester prenatal care. To show an increase in preventive services, to show a decrease in hemoglobin A1C, and show better blood pressure control. So I think we're going to put some healthcare outcomes in there, but we're also going to put, health outcomes. We're also going to put healthcare outcomes, right? We want to see that ED use is decreased, that rehospitalization, especially after discharge, is decreased. So those are the types of things that you guys can be expecting, and the requirements around reporting, I believe, is quarterly. I'll have my team. I mean, there are details that we're fleshing out. We just haven't all come together and agreed on. So I don't want you to think that we're going to be scrambling in the next 2 weeks to come up with stuff. We're just actively working on it. If there's specific outcomes that you're like, you know what, this really matters to rural Indiana, then please let us know that, like ASAP.
No, those all make sense. I wondered if, specifically what you just mentioned are based on rurality, like only as it pertains to rural mothers versus statewide maternal health outcomes, or if that makes sense.
I think it would be based on rurality, right? Because that's where the funding is
Designed
is flowing. Yeah.
Did we just make up a word?
Rurality.
No, guess we.
As a person recovering speech impediment,
Yes.
reality is hard.
Okay. All right, so I think, are there any other questions about the regional grants? So we can move on to the next. Okay, so Eden, do you want to continue on the Meet Indiana Rural Families where they are?
Sure, happy to keep going. Our next goal, Meet Indiana Rural Families where they are. 2 initiatives are nested under here. One of them is improving readiness for emergency departments related to pediatric and obstetrics. This is based on existing work that has been around for a while, essentially ensuring that when kiddos show up in the emergency room, they have the resources, meaning the emergency rooms, have the resources for those kiddos to be well taken care of wherever they go. Same with moms who are pregnant or postpartum, that those emergency rooms are ready and capable to take care of those patients.
Tammy,
Yeah.
again, so are those based on evidence-based standards? Like, I know we've already done some work with AIM bundles.
Yeah.
Will that be tied in?
Yeah, absolutely. And Dr. Hazel, I don't know if you want to talk a little bit more about this.
Sure, this is Eric Hazel from DHS and EMS. Kind of broad-based SIM-based training, some, enhanced certifications, equipment, just kind of spanning all sorts of readiness and making sure it's not just equipment, but other things that are enduring as well. So I think it's a nice combination of everything, both for the OB and PED side of things. So, and that includes outfitting all our EMS units in our rural areas too, which is will be a big change for us in a good way.
Thank you. I mean, this has the potential to save lives very quickly, both for our kiddos and for our moms, and coming directly from data, statewide data about mortality data. Any other questions about this one or comments? Awesome, thank you. Our next goal, connect disparate systems to centralized care coordination, establishing a statewide medical operations coordination center. This is a 24/7 hub for day-to-day hospital operation reporting, helping with patients transfer coordination to the right place. So if that's psychiatric care, if that's the emergency room or wherever, and then EMS resource alignment. And again, Dr. Hazel, if you have anything else you want to add to this.
No, I'm happy to take any. I'm sorry, Eric Hazel from DHS EMS. Happy to take any questions on. I think we've talked about this plenty, but happy to clarify or offline if anybody has any questions.
I have this is Mitch Rowe. I do have a question on this one. So I assume you're anticipating this being a 24/7, 365 physical facility where it was located someplace.
Some sort of call center or
Okay.
something, yeah.
Do you have a location in mind?
Not yet, no.
Okay.
Yeah. And I think they could be integrated with 988, some of those call centers or whatever,
Yeah.
yeah.
211. So first of all, she runs a
Yeah.
211 call center. You probably know that, right? That's virtual, and that's done frankly better than I thought it would, right? Point number one. Point number two is that we found in my previous, that doing this in a physical location outside the 317 area code was cheaper because you could get people who would work less expensively and you could, and they were longer term, better employees, honestly. But that's my 2 cents.
I think also in order to have that knowledge of the rural environment, getting outside into those, closer to some of those areas, to understand the resources available, because that's the only way it's going to run as efficiently as possible, is to know those local resources in the rural area and how to cross some of those geographic boundaries.
This is Kara. Sorry, this is Kara, that wasn't very long. With RHA, this is different than the RMOC,
No, same.
is the same. So we have statewide mock, and then we have a region, in the different regions, we have.
I think that's the discussion we have to have, is what that looks like. We start out one state and then, depending on utilization and things like that, I think we'll have to figure that out, to be honest.
Okay, but I guess, is that like the region decides that they want an RMOC, or does that go into the regional grants model, or?
I think it'd be a statewide initiative, and then use utilization to guide, if we're getting inundated with calls, then yes, we probably need a north, central, south. If, it's slow, then, we could grow with it or something along those lines. A regional model would work, but I think to truly see it, it's going to span even the regions.
It will,
You're going
yeah.
to see people transferring from, southern Indiana all the way to 317 and things like that.
Yeah, and does that include air transport too?
It will.
All transport?
This is Tara. I think that's specifically why we removed the word regional from that one, because I think that the statewide model is the place to start, and then as we progress with the regional health grants, we'll figure out where we are. Any other questions on the mock? All right, moving on to the one initiative that I am most interested in, is the Indiana Community Connections. As the director of 211. So we're state funded, statewide, state run. We're one of the few in the state or in the country. There's like 240 211. So we've done it really well in Indiana. State taxpayers are already paying for the resources. So our job is to get those resources out as best we can to different communities. So it's not just dialing 211, it's really figuring out. So I'm a provider in a community, and a lot of times some of their health outcomes are based on their social situation, like where they're living, how they're living, their lifestyle. And so there are resources available to them oftentimes, but the providers aren't necessarily, that's not necessarily what they're trained in. So there's an opportunity for us to build out like a closed loop referral inside these regions and wherever someone is, to be able to get access to the data. So we will work with whatever organization to get our resources there. There's a lot of EMRs that there's a component that you can add on, but it costs money to do that, and so that's a barrier. So with this funding, we could foresee the opportunity to add that module, maybe even statewide for whoever's using this particular system that can just add that module, and then we can integrate into that with our data. So we've been working for several years. We've been with the state. We transitioned in 2020, so it's been 5 years. So we're really in a much better position than we were 5 years ago to even have this conversation. So it feels like good timing to use this as an opportunity to get people connected to resources within their own community, because I think what people don't realize when you're isolated, you just don't realize that there are things out there and there are resources out there that can help you. And you can't assume that there isn't something in every community, because we know there is. It's just making that connection. So that's the Indiana Community Connections.
Cami from CareSource. Will this include the technology that's necessary? Because closed loop referrals will require some data sharing.
And our current system is able to do that. Again, we weren't there 3 years ago, so this conversation wouldn't even be on the table. So we're in a perfect position to figure out how we do that and who we can share the data with. So there's technology, it's a technology solution. We already have the data, we just need to get it to the people who need it.
This is Kara with IRHA. Is that a one-time influx of dollars then? Like to get the technology established, interfaces with the EMRs and then?
Well, and that, I don't know
manages
enough
itself?
about how the EMR charges for those additional models, but they're paying for their EMR. So there could be some, I don't know what that looks like in 5 years for those EMRs. But yes, the idea is that this is an influx to get this. We've talked about it for a long time, but to actually make this happen because the funding's available. Because we don't have funding to help the hospitals or the clinics or whoever is could access the data. And it hasn't been viewed necessarily as a priority for some organizations. So I think this gives us the opportunity to actually make that happen.
This is Eden. I'll just pop in a little bit more. This is similar to a model that we admire in North Carolina, which enables even provider to provider referrals. So if you're in Daviess County and you know that you want to refer someone in your waiting room to the food bank, you don't have to do that. You don't have to, Indianapolis doesn't have to air traffic control if it's not needed. If you already have that trusted partnership in your county, go for it. Make that referral within a system, which I love because like you want to know that that patient is being picked up by someone else when you send them out into the universe. So this kind of community approach, I think, helps with the the uncertainty that providers may have of saying, well, okay, I'm going to send you with a list of referrals, and I hope that someone picks up the phone when you call them. So good luck. No, there's some accountability on the other side. If that food bank isn't picking up the phone and getting connected with that individual, then there's some accountability there too, which I think is really a nice next step into the next iteration of 211. It has been acknowledged, and I think about this too, is then that continued buy-in on the community-based organization approach too, right? So it's beyond just having the right list of resources. It's making sure that those lists of resources are ready to take families when they're being referred to. So it is that kind of two-way commitment, right?
There was a question online that asked about the mock from Scott Smith. I said in the context of the rural health transformation, the majority of calls to the center and the majority of transfer coordination benefit would actually be for suburban and urban areas as opposed to rural areas, and if that was a concern.
I'm not sure that's true.
I'm sorry, it's Eric. I would probably, volume-wise, yes, you may see more from our mid-sized hospitals to our tertiary care centers. The ones who really struggle are sometimes our rural areas where you get left on an island and you see the long delays and things like that. So would it benefit some of our, semi-urban and stuff? Yes. But will it provide a safety net for our rural facilities? Absolutely. So.
And this is John too. The mock itself can work in both directions. So not only, we're also returning people to levels of care in their own communities as well, which would be rural, knowing that is a better support system for them.
And the patient smoothing will help everybody, to be honest. You've got one place that's got 20 transfers waiting and another facility that's wide open. So I think getting patients in their appropriate facilities in a more efficient manner helps declog the system for everybody.
And I don't know if that can be an outcome measure, but I think that's one of the biggest concerns I've heard from rural communities. Like, gosh, I'm not sure about this model because I'm not going to get my patient back. Is the concern that has been presented to us before. But every mock we've talked to has said, we build in not fail safes, but processes to ensure the patient gets back to the community. But until you can see it on paper as an actual outcome that proves that it does go back, that would be, I don't know how you do it. You know more about that than I do. But if you can build that as an outcome that shows the patient's back to their home community or,
Ideally, you'd have facilitated discharge planning with connections with care in their local area, mobile integrated health, other things to keep them in their area, basically decrease their length of stay when they are away from their home, and then allow them to recuperate in their hometowns, with the facilitated discharge planning as well, coordinated by the RMOC. So.
This is Kara again. I don't know enough about the CBOs on the back end of the referral from 211. Are they required to report back to the healthcare organization? Like, how do we know I know it's intended to be a closed loop referral, but how do you know the patient gets referred to food bank? That they actually got the service that they were being referred to? I don't know enough about CBOs to do.
Yeah, so they would, that's engagement that has to happen. So that's where some of this money is building that out. So people are aware, like if you do this, again, we haven't had this before in Indiana where all the resources, we still have people keeping lists in some small areas. And, when they find out that we are statewide and they can use our information, then, it frees up time for them to do other things. So in the CBO situation, there's no cost to them to participate.
Right.
So once they are able to get into the system, they just put in their notes and then it's visible to the others who referred. So that's the whole point of the closed loop, is that you can see what happened. So I can refer somebody to Eden and she says, oh my gosh, I'd love to help this person. And she calls them and they work something out. She puts the notes in and then I can see, oh, this person got help, but she also referred them to 3 other organizations. Or she could refer back and I could outreach to refer them to, their next need. That's what we see. It's never one need. It's usually multiple needs. Yeah.
Visibility to this would be really great for MCE, so I will just plug that.
Yes.
That would
It's been my dream for 3 years now. Yes.
Very helpful for us.
We've been working on that, so yes, that's all part of it. And I think we also need to mention that, MCEs are part of this conversation as well as we move forward, because, a high percentage of our rural population is covered under Medicaid, with Medicaid, and our MCEs cover so many, participants in the Medicaid program. So it is really important that we're keeping the MCEs aligned with what we're doing and helping us with some of those health outcomes as well, because they might see some changes on their side as well, or enhancements of what they can do to promote some of the things that we're doing, which can be really helpful.
We appreciate the inclusion.
All right, next is workforce development.
Want to do this one again? All right, this is Eden again. We have a suite of initiatives related to growing the rural workforce. So this is one of those initiatives that will kind of be working in parallel with those regional grants, right? So we want, as the state, to build out the capacity and capabilities for things like community health workers, making sure that there's enough slots for residents, to make sure that there's enough of the workforce to happen, which will happen at that state level. And then we want our regional teams to be employing those people that we're growing here. So as you can see here, some certification and training curriculum related to community health workers, some work related to preceptorships and graduate medical education programs. You'll see that we struck out student loan repayments. That came in a recent frequently asked question from CMS indicating that would not be supported by the administration. So we're kind of thinking a little bit differently about how we want to approach that aspect.
Do you know what the reason for that was?
Sustainability. So they do not want to see things that are just going to drop off at the end of the 5-year periods. Understanding though that if you have that professional in your region continuing to provide that service, that's still long benefits, right, even after the end of that student loan repayment. So thinking about the balance of
Yeah, I think that's the most impactful thing you can do. So that's unfortunate.
Can you, for the
Gloria.
community health work, I'm sorry.
Oh, hi, everyone. So hard to jump in, but thank you for your attention. I just got off of a CMS office hours that was from 2 to 3, so pardon me for joining late. And there were a lot of questions about workforce. So they presented 20 minutes of slides based on the FAQ that was posted on Friday. They did discuss student loan repayment. And then there were about 40 minutes of questions. There's another office hour this Thursday. I sent John the link. But they did say something interesting. While student loan repayment is not permitted, there is, and you can't call it scholarship because scholarships are not permitted, but there is some language in the NOFO and in the FAQ where we can provide it for educational, like supplemental funding. And so you'd have to grab the exact language. And folks were saying, can we give students scholarships? And they're like, well, you can't call it a scholarship, but it is permissible. So that's one thing. The other thing that I thought was interesting when I met with, I was at Marian University yesterday and met with the president, the chief medical officer, GME head, and they, the dean for the med school, she brought up that student housing is a real issue because when they go on rotations in this regional model that we were talking about, just how, and I know from being a preceptor for students, they just have to go find their own housing and they pay really high prices. And she said that was a barrier and it'd be very challenging in rural areas. So if just student housing could be considered, then the question was asked, could that be covered by the Rural Health Transformation Program? And the answer was yes. So again, I just wanted to flag those for you in case the group was interested. Thank you. Oh, and this is Gloria Thatchett.
Gloria, this is Mitch. Do you mean rent or the building a physical asset?
Both. So the one was, you can't use it to build like brand new buildings, but you can use it, they said, to modify existing structures. So if there was an apartment complex, basically if there's an apartment, then it could be used for student housing, maybe at like a discounted rate or something like that, depending on what the costs are, and that would be permitted. The caveat to that is it's only apartments for short-term lease of 6 months or less. So it really is for students, because no one's on rotation more than 6 months at a particular time. And then residents, if we were thinking about residents doing, 4, 5, 6 months in a rural hospital inpatient, then going back to the main hospital system for some of their specialty training, that could be used in that situation as well.
Thank you.
This is Kara again. I have a question on the community health worker thing. Any idea on outcomes to measure that? The reason I ask is it is a fabulous paraprofessional support to the physician and the patient. The challenge is sustainability because it's yes, it's reimbursable, but not in a sustainable way. So is there, I don't know if we can identify some sort of outcome measures that demonstrate the ROI that offsets the cost of the employee, that, somehow comes back full circle, that shows decreased readmission, improved follow through with care. Those are just some of the outcomes, but ultimately ROI, I think, to the healthcare organization would be beneficial to demonstrate the value in a tangible way.
Yeah, thanks, Kara. I appreciate that. I don't have a good answer for you yet, but appreciate the feedback.
I like the outcome piece.
Okay, we'll move on. We've got 2 more slides to go through. So next up is innovative care, meeting rural, and that's where they are, continuation of this. Meds to beds.
Meds to beds. All right. This is the one that I admittedly probably know the least about, but it helps patients leave hospitals with the medication that they need at outpatient prices. Is that a fair and reasonable way to describe it?
Those programs have been in existence and they are very successful.
And the barrier here is that people, when they are dismissed or discharged from the hospital, from the hospital, that they don't go pick up their meds or they don't know what to do. So if they have them in hand, then.
This is John. This would be for all medications, but especially around those chronic and acute conditions, knowing that many people are returning back to their communities with limited ability to travel, or those pharmacies are not operating at sometimes all the hours that we would expect in some of our urban environments and that we're used to. But also some of these pharmacies due to the, are not stocking these medications. And so this will help with making sure that people are taking the medications and with those readmission rates as well. Part of the money that is going to be going to this will be to help those rural and small hospitals develop the infrastructure that they need for this discharge and the programs then for the medications.
To build retail within the hospitals?
Yes, help with the program, yes.
Not
They
just
could
meds to beds, but a full retail pharmacy within the hospital or separate?
I think that would be separate. I would have to double check on that. I apologize.
It
Not
could be,
included.
Sarah, it could be a retail pharmacy in there, but in some instances, it is just partnering with the local pharmacy to be able to provide that. So it'd be up to the hospital about what would meet their needs. I think we have to acknowledge that there is limited pharmacy access in our rural communities, and so any way to be able to help in this standpoint will be good.
Gotcha.
Is
Thank
this
you.
inclusive of psychotropic medications and patients leaving treatment centers, whether that's children going back into their rural communities and access to their medications?
Sarah, that's a really good point. This Katrina with DMHA and the psych hospitals, also the long-acting injectables. If you're talking about chronic disease prevention and readmission into ED,
Yes.
that long-acting injectable, if they could get that 30-day window, you're less likely to see them engage with EMS, ER, or law enforcement for that matter. So.
And this is John. So Sarah and Katrina, maybe you guys can send us kind of the best practices that you guys would like to see modeled in here, and we can make sure that it's incorporated in that draft.
Perfect,
Awesome.
thank you.
Thank you for that question.
Okay, thank you guys. Next one here is improved specialty provider access to expanded teleconsult capabilities, right? So we want to keep patients in their rural areas to provide teleconsult capabilities. Some of this, again, this is one that kind of mirrors the regional brands. We want regional teams to be able to buy the technology to be able to do teleconsult, but we need that network at the state level to then connect people to those specialty providers. And that's just going to look different wherever you are in the state. Tech innovation kind of moving along. It's telehealth, same, right? Making sure that you have the capabilities for families to get telehealth services, and that our care teams are leveraging telehealth in their areas.
The difference with that versus the improved specialty provider access, that's e-consult versus telehealth, right?
Yes, so patient to provider versus provider to provider. Yep. Thank you for saying that out loud. Medical interoperability. Again, this is one of the ones that I probably know least about, but things talking to other things to change to move data and whatnot. So that's
That's exactly what it
yes,
is.
my 5-word summary of medical interoperability.
So basically, you could have a patient who transfers from a rural hospital up to a bigger hospital, and there's no information, that is accessible for that larger hospital to see what's going on. Now we're repeating tests, we're doing all kinds of things that if we had access to that information, we could move forward.
Are we going
It's
to be
also
more
long-term
specific?
care facilities. It's also primary care providers. We are very disconnected for being lauded as one of the most connected states. But when we say that, it's because 80% of our hospitals are connected, but beyond that, there's very little information sharing among healthcare providers. That is a huge gap in our ability to care and for our ability to save money and not repeating unnecessary testing. So it's beyond just the hospitals. It's the other healthcare providers, behavioral health as well, mobile integrated health. We don't have access to our EMS data. And then I think that's enough.
Yep. Thank you for that additional.
Thank you, Dr.
information,
Weaver.
Thank you.
And that's it.
And then here's our funds distribution news deadlines. Just FYI, we will have multiple grant periods open at the same time. So it gets a little bit, it's a little bit interesting to track. So we get the first influx of money, assuming we qualify, are approved in January, and then we have until September 30th of 2027 to spend that initial year. But then we start, they reassess in October, and then we start the second year in 2026. So
Just let me say that Paul Bowling, our CFO, is so excited to get his team into this and working hard.
It's Paul Bowling. It's above excitement to get the money. No, it'll be all good. We'll definitely get it worked out and best get it out and stuff.
All right, this is Mitch Rowe again, and just wondered if there were members of the community who had questions beyond what they've already asked. Seeing none, I'll thank each and every one of you for your engagement in the process, both today and throughout the last several, it feels like weeks, but I guess it's been months that we've been at this. Continue to ask questions. We're probably going to go into
a little bit of dark mode.
a little bit of dark mode, yeah, thank you, to get this thing done on time. But just because we don't respond doesn't mean we didn't read it. Also doesn't necessarily mean we read it. All right, thanks very much for your time. Have a lovely afternoon.
Thank you, everybody.